right, sorry we're having a lot of interruptions today. It's a crazy Monday. So we're on page 38. We are in advertising and signage. So the State Board of Pharmacy may have requirements or restrictions regarding signage and advertising. Some pharmacies, they advertise prescription drug prices to the public, like $4 generic drug listings, $10 generic drug listings. This is allowed by the FDA and is considered to be reminder advertising. Some state boards may require pharmacies to post a public notice to alert patients about business hours as well, and hours when a pharmacist on duty is temporarily away, like on a meal break, as well as right to counsel or the availability of interpreter services. All right, moving on to renaming, relocating, or closing pharmacy. A change of business name, a closure, or a relocation of the pharmacy will require notification to the state board within a set time limit. It could be immediately or within 30 days. Many states require inspection of the new site prior to approving a relocation request. In some jurisdictions, all that is required is a relocation notification of the move to the state board, which is made by simply completing a change of address form. The DEA will require change of address notice for the registrant when scheduled drugs are being moved from one location to another, such as with the relocation. Transfer of scheduled drugs will be discussed further in the Controlled Substances chapter, part 2. Moving to page 39, record keeping. So all pharmacies are required to keep records related to patients and prescriptions and pharmacy operations. Records can be stored in hard copy or electronic format. They can also be stored in a combination of the two. The pharmacy policy and procedures, the P&P manual, should detail all of the record-keeping procedures, including what to do in the event of a power failure or other situation that interferes with the use of the electronic system. All pharmacy records, whether they're paper or electronic, have to be kept secure. They also have to be readily accessible. Most records must be stored on site at the pharmacy, but some states permit off-site storage of certain records. When this is allowed, the pharmacy often has to meet additional conditions, such as having the ability to access the off-site records within a specified time frame. So, for example, within 2 business days. Records that must be kept by pharmacies include the following. So let's see, we have 1, 2, 3, 4, 5, 6 subsections. So we have to keep patient profiles for each person who filled a prescription. This includes patient name, address, phone number, date of birth, gender, drugs that were previously dispensed, and any other information that the pharmacist feels is important. Secondly, we have to keep dispensing records for all prescriptions. So again, this would include prescription number, name, and the manufacturer of the drug that was dispensed, the quantity dispensed with each fill, the name or the initials of the dispensing pharmacist, the date of the fill or refill, and the number of refills remaining if applicable. The third subsection Receipts need to be kept for all drugs purchased and received by the pharmacy. So this includes transaction information, or TI, transaction history, TH, transaction statement, TS, in order to satisfy requirements of the Drug Supply Chain Security Act. Compounding logs have to be kept if the pharmacy compounds. The DEA Form 222 and other controlled substance related records like inventories need to be kept by the pharmacy. And the last subsection here, there should be a logbook for the OTC sales of Sudafed and ephedrine containing products. So this is the over-the-counter products logbook, and this is covered in more detail in the OTC products chapter. Most states require all or most records to be maintained for a minimum of 2 years, though some record requirements for different states would be maintained for a longer period. So again, if they ask about federal record requirements, most states would require, or the federal rule would be, to maintain these records for a minimum of 2 years, but this will vary state by state. So some states will require records to be maintained for longer periods. We're on the bottom of page 39 under institutional pharmacy heading. So an institutional facility provides a physical location for patients to receive extended healthcare services. So this is like a hospital, an assisted living facility, a long-term care facility, a nursing home, a rehabilitation center, a drug abuse treatment center. An institutional pharmacy provides pharmacy services to any institutional facility and may or may not be physically attached to the facility. So when a pharmacy is not physically attached, a licensed nurse can be authorized to restock automated dispensing systems with verification technology such as barcode scanning. A valid prescription drug order in an institutional facility is called a chart order or a medication order. These drug orders are entered directly into the chart or the medical record for the inpatient or institutional facility resident. The order is going to be ongoing until the prescriber would discontinue it, unless an automatic stop date is specified. So again, the prescription drug order is ongoing until the prescriptor DCs it, unless an automatic stop date is specified. A chart order would be exempt from the standard prescription requirements discussed in the pharmacy practice chapter. Instead, a chart order must be, the chart order must include the following items. So we have 1, 2, 3, 4, 5. So it has to have obviously patient's name, the date that it's being issued. So that's 2 things. The third thing is it has to have the drug name, the strength and dosage form. Fourth is it has to have directions for how to use it or how to give it. And the fifth thing is the prescriber has to sign the order or the signature of the patient's licensed healthcare designee along with the prescriber's name. All right, so moving on, we're on page 40. So we're under the heading absence of a pharmacist in an institutional facility. So a pharmacy within an institutional facility might be without a pharmacist for designated periods like overnight. The pharmacist in charge must have procedures in place for authorized individuals to obtain medications, and there must be a pharmacist on call during the absence. So a supply of drugs should be available in a locked cabinet located outside of the pharmacy, such as the ADS, the automated dispensing system, or it also could be stocked in the night cabinet. For emergencies, the pharmacist in charge has to grant pharmacy access for authorized people. Each facility has to designate authorized individuals who can access the locked cabinets or access the pharmacy. The next heading is emergency kits. Institutional facilities, including long-term care facilities, they may utilize emergency kits to store drugs that may be needed. These drugs may be needed urgently or immediately to prevent patient harm, and they are not otherwise available in a timely manner. So again, long-term care facility or an institutional facility, they may use emergency kits to store drugs that might be needed immediately. So think like an EpiPen, right? The drugs and quantities available in the kit have to be decided upon by the facility's medical staff as well as the pharmacy or pharmacist. The kit can contain non-controlled as well as controlled drugs, as long as the pharmacy supplying the controlled drugs complies with all state and federal regulations. The pharmacist will prepare and seal and store the emergency kit in a secure location, and this will only allow for authorized access. The expiration date for the kit must be the earliest expiration date of any drug contained within the kit. When the kit expires, then the pharmacist has to replace the expired drug and update the kit's expiration date. A drug should only be removed from the emergency kit pursuant to a valid chart order. The supplying pharmacy has to also be notified anytime the emergency kit is opened. The pharmacy will then restock and reseal the emergency kit. A label must be on the outside of the kit to designate it as an emergency kit, and list the following information. So each drug name and strength and quantity, the expiration date, the name, address, and phone number of the pharmacy that supplied it. Moving to page 41, we're going to go under the heading of automated dispensing systems and long-term care facilities. So the DEA permits retail pharmacies to install automated dispensing systems in long-term care facilities in order to remotely dispense non-controlled and controlled medications. The automated dispensing system is also usually sometimes called an automated dispensing cabinet or an ADC. So you may know this by the Pyxis or the Omnicell. So the automated dispensing system or the automated dispensing cabinet, it electronically records and dispenses single unit doses of medications. The pharmacist has to enter the chart order into the system before the medication would be dispensed from the automated dispensing system. With the exception of an emergency override, which should be strictly limited. The drugs that are stocked in the automated dispensing system or the automated dispensing cabinet are considered pharmacy stock and not long-term care facility stock. And that's before they are dispensed, okay? The pharmacy must have a separate DEA registration for the automated dispensing systems that are located at the long-term care facility. Only authorized long-term care facility staff members are actually allowed to access these automated dispensing systems or automated dispensing cabinets. One advantage of utilizing these systems and cabinets is reducing waste of controlled substances, which can occur when the patients might pass away, or if they're discharged from the facility, or they have a change in their medication regimen. Again, because it's unit dose, right? It's not like a 90 count of pills that gets wasted. So using the automated dispensing system, it is a more convenient and less labor-intensive way than it's a system that is more convenient and less labor-intensive than preparing daily medication cassettes, right, for each patient. That makes sense. So the next section is telepharmacy. So some states have patients or pharmacies that are remote or in rural areas. And so these remote and rural areas, they were the first to enact regulations for telepharmacy and telemedicine. And it was put into effect essentially to improve healthcare delivery to these underserved communities. These regulations allow virtual pharmacy practice using remote order verification, video conferencing, telephones, the internet, as well as they might use the automated dispensing systems. Telepharmacy provides pharmacists with a means to verify prescriptions, perform drug utilization reviews, and to counsel patients remotely. State laws usually require remote telepharmacy sites to have a pharmacy license in order to receive third-party reimbursement. It's true. Patients bring prescriptions to these remote telepharmacies, which are staffed by typically pharmacy technicians or maybe nurses. The central pharmacist will supervise the workflow over a teleconferencing system or security cameras. They will be in the central store location, but they will be supervising a satellite pharmacy that doesn't have a pharmacist. And they will verify the prescriptions that are transmitted from that telepharmacy site. The prescription label and pre-packaging medication will then be dispensed at that remote site. The pharmacy technician will scan the barcode, attach the label, and dispense the medication to the patient. Finally, the pharmacist at the central location will counsel the patient through real-time video. We're at the bottom of page 41 under P&Ps, so policies and procedures. The majority of states require every pharmacy to have a current policies and procedures or P&P manual. A policy is a course of action for a specific activity, and the procedure written into the policy includes the steps involved that must be carried out by the staff. It explains what to do for the various expected and unexpected events that occur in the pharmacy. Policies and procedures, P&Ps, help keep the pharmacy running efficiently. The manual can protect the pharmacy in case of litigation and may be required for state or insurance company reimbursement. Select states will require pharmacists to prepare the P&Ps, the policies and procedures, for all pharmacy operations, and others identify the types of P&Ps required. All of the policies and procedures, the P&Ps, must conform to federal and state laws and regulations. All right, we're on page 42. We're on quality assurance heading. The most common error that is made by pharmacists and pharmacy staff is giving the wrong drug to the wrong patient. The wrong drug to a patient. Most boards of pharmacy require pharmacies to maintain a continuous quality improvement or a CQI program. So when a medication dispensing error occurs, an investigation needs to be performed, which is also called the root cause analysis. The continuous quality improvement program has to include 5 subsettings here. So first we'll say parameter. The first parameter of the continuous quality improvement program should be designated individuals responsible for the program, including implementation, maintenance, and monitoring. Secondly, a set time frame under which the continuous quality improvement CQI is initiated after the medication error is discovered. So the Board of Pharmacy, the NABP, recommends that the investigation be initiated within 3 days, that the individual state boards may have more stringent requirements of 1 or 2 days. The NABP, the National Association of Boards of Pharmacy, recommends that the errors are reported to an appropriate nationally recognized program, such as the FDA or the Institute for Safe Medication Practices, the ISMP, which offers online medication error reporting. Third parameter here, formulation of a plan to amend the pharmacy system and workflow in order to avoid a repeat of the same or similar types of medication errors. Fourth parameter, implementation of recommended changes in the pharmacy systems and workflow processes. And then the fifth parameter, education of the staff performed on a continual basis. On safe practices, lessons learned from the continuous quality improvement, the CQI, must be passed on to the rest of the team. The NABP, the National Association of Boards of Pharmacy, recommends that each pharmacy conduct a self-audit at least quarterly to assess the frequency of medication errors, and a survey of the customers or a sampling of the customers at least annually, to help determine patient perception of pharmacy's quality. Alright, so peer review is another part of the continuous quality improvement CQI process that should be conducted periodically to ensure that the pharmacy's quality standards are met by the facility and the pharmacy staff. It can be done by an individual or by a peer review committee. can be done by an individual or by a peer review committee who is responsible for collecting data and providing feedback to improve patient services. In addition to evaluating pharmacy systems, peer review can be used to assess pharmacist competencies and assist in correcting any deficiencies. It should not be used as a punishment for reporting errors. The goal of the peer review process is to prevent negative events from occurring. The peer review process will vary between states, but the following steps are recommended to facilitate its development. So we have 1, 2, 3, 4, 5, 6. So first, select members for peer review committee. Second, set quality standards. Third, develop reporting procedures. Fourth, evaluate activities against the standards. 5, make recommendations based on the evaluations. 6, conduct self-audits of peer review system. Page 43, temporary absence of the pharmacist. Fatigue that results from continuous physical and mental activity can cause lapses in attention and lead to dispensing errors. Breaks are challenging when there is one pharmacist on duty without a pharmacist present. Dispensing new prescriptions and providing counseling is prohibited. Several of the states specify additional restrictions if one pharmacist is on duty alone. We're gonna move on. We're on page 43. We'll take a break here, but we're gonna get into drug supply chain integrity, drug storage, drug recalls, drug delivery, vacuum tubes, drive-up windows, and public health reporting requirements. Take a pause here.